Lung cancer. Etiology and pathology. Smoking remains the chief cause, although other etiological factors include asbestos, arsenic, and some heavy metals. Various histological types are recognized. Table 34. Epidemiology. Bronchial carcinoma is one of the leading causes of mortality in the UK with around 35,000 deaths per year. It is more common in men, although the incidence in women continues to increase, male to female ratio 2:1. Clinical presentation. Common. Any abrupt change in respiratory symptoms in a past or current smoker merits investigation. Cough. Hemoptysis. Shortness of breath, may represent an effusion or lobar collapse. Chest pain. Uncommon. See Table 35. Rarer presentations reflect the vagaries of anatomy or distribution of metastases. Wheeze or stridor. Dysphagia as a result of esophageal compression by enlarged mediastinal nodes. Nerve involvement, e.g. hoarseness secondary to recurrent laryngeal nerve palsy. Horner's syndrome. Neuralgic pain as a result of tumor spread, e.g. Pancoast syndrome and rib involvement. Loss of power and/or numbness in a limb or confusion resulting from brain metastasis. Facial swelling caused by superior vena cava obstruction, SVCO. Confusion secondary to hypercalcemia. Confusion secondary to hypoatriemia caused by syndrome of inappropriate secretion of antidiuretic hormone, SIAD. Cushingoid features and/or increased pigmentation, ectopic adrenocorticotropic hormone secretion. Physical signs. Examination is often made with the benefit of a CXR. Common. Look for clubbing, tobacco-stained fingers, cachexia, pallor. Uncommon. Lymphadenopathy, feel carefully, including behind the sternomastoids and deep behind the medial clavicle. Evidence of consolidation or pleural effusion on percussion and auscultation. Liver edge secondary to metastases. Bone pain caused by metastases. Facial swelling and collateral venous circulation. Rare. Stridor secondary to tracheal or main bronchus involvement. Horner's syndrome. Pigmentation. Skin metastases. Investigations. Chest radiograph. Posterior and lateral views help to localize the lesion, especially for the bronchoscopist, Figs 29 and 30. Bronchoscopy. If there is a visible lesion. Biopsy for histology. Washings and brushing to cytology. Washings to microbiology for microscopy, sensitivity, and culture, and acid-fast bacilli. Remember that infection can mimic carcinoma. The surgeon will want to know the endobronchial anatomy. CT scan. For staging the tumor, the scan needs to include the thorax, liver, and adrenals to look for metastases, as well as the brain if there is evidence of neurological involvement, Fig 31. Percutaneous biopsy under CT guidance. This is useful when bronchoscopy does not establish the diagnosis. The patient should be warned that there is a 10% chance of pneumothorax and must be fit enough to tolerate such a complication. Mediastinoscopy. Mediastinal nodes shown to be enlarged on CT or MRI are biopsied. This helps differentiate hyperplastic lymphadenopathy from tumor invasion. This can alter tumor staging and therefore operability. In some centers the nodes are sampled and analyzed under frozen section before proceeding. Positron emission tomography scans. These are becoming a useful tool in identifying tumor involvement of mediastinal nodes as well as other local spread. Sputum cytology. This is mainly useful in patients who would not tolerate a bronchoscopy. Blood tests. These are not diagnostic but can identify complications. FBC, anemia may indicate progression of disease and/or bone marrow involvement. Urea and electrolytes, decreased sodium may indicate SIAD, increased urea dehydration. Liver function tests, if deranged may indicate metastatic disease. Differential diagnosis. This is of the presenting problem but could include infection, consolidation from a pneumonia or tuberculosis, lung abscess, bronchial adenoma. Complications. The vigor with which complications are treated will depend on the patient's general performance status and local expertise, Table 36. Treatment. Emergency. Radiotherapy, DXT, for SVCO or tracheal bronchial obstruction. Laser bronchoscopy or stenting of tracheal or main bronchial obstruction, requires swift referral to a specialist center. Pain control, early referral to Macmillan Palliative Care Team. Short-term. Surgery. The most important step is to decide whether the patient is a candidate for surgery. Age should not be a barrier for referral. Those with solitary peripheral lesions should always be referred. In general, patients presenting with central lesions, metastases, or SCLC are not candidates for thoracotomy. If in any doubt, always make a swift referral to your local cardiothoracic surgeon, as in most cases resection is the only treatment likely to be curative. Make sure the patient comes back to see you immediately if turned down for surgery. Non-surgical treatment. Radiotherapy. High-dose DXT with curative intent may be given to patients with NSCLC without metastases who decline surgery. Patients with extrathoracic spread are generally given a palliative dose to control local symptoms, as high-dose DXT has not been shown to alter prognosis, but can lead to considerable morbidity. Prophylactic cranial DXT in SCLC has been shown to improve prognosis. However, postoperative DXT following resection does not improve prognosis. Chemotherapy oral and/or intravenous treatment is given with DXT in small cell disease. Trials continue to evaluate its usefulness in NSCLC and before or after lung resection. Pain and symptom control. It is essential to introduce patients and family to support teams as soon as appropriate. Prognosis. Overall 5-year survival is 5.5%. Prevention. Smoking cessation. Never underestimate your ability to counsel patients about smoking cessation. Your words may be just the crucial encouragement the patient needs. Particularly if you have never smoked, do not appear distant and virtuous. Imagine your worst habit, even if it is not life-threatening, and how difficult it would be to give up. Recent government-sponsored initiatives in the UK may lead to increased availability of clinics to help people quit smoking. It is worth knowing what is available in your area so that you can readily advise. More often than not, nicotine replacement therapies are available on NHS hospital formularies, so have an idea of what is available and encourage patients to see their GPs for further advice. Preparations include nicotine patches, gum, vaporizer, inhalator, sublingual tablets and nasal spray. And B. Encourage patients to quit, help them set a date on which to stop and refer them to a specialist smokers clinic if appropriate. Record your advice in their notes and GP letter, and take the opportunity to ask how they are getting on if you see them again in clinic.